Okay, so picture this. You've just finished a long, vigorous run. You're cooling down, and you reach for something fresh, raw, and hydrating, maybe a crisp apple, a handful of walnuts, or a crunchy celery stick.
Yep.
You take a bite, and immediately your mouth starts to itch, your lips tingle, your throat feels scratchy and weird, maybe even a little swollen, but here's the kicker. It's mild, it only lasts about 20 minutes, and then it just vanishes without a trace. That momentary confusing reaction, that is the classic presentation of pollen food allergy syndrome, or PFAS.
It's a textbook case of immunological mistaken identity, really.
Yeah.
And it's a concept that is so critical to distinguish from a true primary food allergy.
Right.
We historically called this oral allergy syndrome, or OAS, but PFAS is the much preferred, more accurate terminology now.
Why is that? Where the change?
Well, because it clearly links the food reaction back to the inhaled airborne culprit, existing pollen sensitization. The food you see is just collateral damage.
That distinction, the food being collateral damage, that seems fundamentally important. So we are absolutely not talking about a classic immediate food allergy where a specific protein, cooked or raw, sends you into anaphylaxis every single time.
No, not at all. The entire engine driving PFAS is a phenomenon called immunological cross-reactivity. Your body was first sensitized to an airborne pollen allergen, and now that same IgE antibody is recognizing a surprisingly similar structurally related protein that's just, hiding out in the raw plant-based food you just ate.
So your immune system is already primed. It's on high alert.
Exactly. The IgE antibodies are circulating, waiting for that signature from the primary sensitizer, the pollen. When you consume the raw food, the proteins in that fruit or vegetable happen to share enough structural features, enough molecular epitopes with the pollen protein to bind those same IgE antibodies.
And that triggers the histamine release.
It triggers the release of histamine, but critically, because of the protein's fragility, the reaction is usually immediate and localized, confined primarily to the oropharynx, so the mouth and throat area.
And this sounds like a quirky niche allergy that only affects a few people in spring, but the data seems to scream otherwise. How widespread is this confusion within the immune system?
It is remarkably prevalent, which is why it demands such detailed understanding. Across global studies, the estimated prevalence of PFAS ranges widely, typically reported to be anywhere from 2% to 10.8% in the general population.
It's already a huge number of people.
It is substantial. But the numbers, they just skyrocket when you narrow the focus to individuals who already have documented pollen sensitization, patients with seasonal allergic rhinitis.
So if you have hay fever, your odds go way up. What kind of proportion are we talking about then?
We see that up to 50% to 70% of pollen sensitized individuals will experience some form of PFAS symptoms over their lifetime. It is extremely common.
50 to 70%. Wow.
And if we drill down on specific, highly prevalent pollen sensitivities, like birch, the numbers get even higher. Studies in Northern and Central Europe, including the UK, show that nearly 70% of birch allergic adults are affected by PFAS.
So the takeaway is, if you have seasonal hay fever, this deep dive is absolutely relevant to understanding why certain raw foods are causing you grief.
Absolutely.
Wow, up to 70% of birch allergic adults. It's a huge population. And that prevalence check leads us directly to our mission for this deep dive. Our objective is to distinguish PFAS from primary food allergy by drilling down into the specific proteins responsible, the panallergens, and then critically exploring the surprising and often overlooked cofactors that can turn a simple, self-limited mouth itch into a severe systemic reaction.
And then we'll analyze the latest international consensus on management, including the revolutionary shift toward molecular diagnostics, component-resolved diagnostics, or CRD, which dictates personalized avoidance strategies.
Perfect. So let's start the investigation at the molecular level, because understanding why a raw apple makes you itch, but a baked apple, doesn't require looking at how food allergens are classified based on their resilience or their stability.
The two big classes, right? Class 1 and Class 2. This molecular difference is the first major hurdle for the immune system.
Okay, so let's break that down.
Correct. We categorize food allergens into these two main classes based on how they react to processing, heat, and digestion. Class I allergens are your conditional high-risk culprits that everyone thinks about when they hear food allergy.
Right. The big ones.
These proteins are highly heat and digestion stable. They are built tough. Cooking doesn't neutralize them. And they are robust enough to survive the stomach's harsh acidic environment completely intact.
And because they survive the stomach, they can travel down into the intestine and cause a body-wide systemic reaction.
Precisely. They are capable of sensitizing individuals directly through the gastrointestinal tract and are associated with severe, generalized allergic reactions, such as true allergies to peanuts, their storage proteins, or shellfish. Strict, lifelong avoidance is the necessary management strategy for Class I allergens.
Okay, so if Class I is tough and stable, Class II must be the opposite, and that's where PFAS comes in.
That's absolutely right. Class II allergens are the exact opposite. They are heat and digestion labile. They are fragile. They quickly denature or, fall apart when exposed to heat or stomach acid, hydrochloric acid, and digestive enzymes like pepsin.
So they don't cause the primary allergy through the gut.
They typically do not cause primary sensitization through the gut. Instead, they trigger reactions only due to that cross-reactivity with aeroallergens, the pollen, that have already primed the immune system via inhalation.
And this fragility is the key protective mechanism for the PFAS patient. Because the protein structure breaks down quickly in the mouth and throat, it doesn't survive long enough to travel further and cause a serious systemic issue.
That fragility is why the reaction is generally localized to the oropharynx, why it resolves quickly, and why cooked or processed forms of the food are almost always tolerated. The molecular requirement for this whole cascade to even occur is a significant degree of similarity, typically more than 70% between the protein sequences of the inhaled pollen allergen and the food protein.
So the IgE antibody needs to see enough of a match.
Exactly. It needs to see enough shared structure, enough shared epitopes to trigger the reaction.
Okay, let's unpack this. Focusing on the three main families of these class II allergens that drive this specific cross-reactivity, starting with the most widespread and well-studied, the PR10 proteins, which is the classic birch connection.
The defining prototype here is the protein known as BET-V1 from birch pollen. This family of proteins is relatively small, around 17 to 18 kilodaltons, or kDa, and they are classified as pathogenesis-related proteins, specifically class 10. Their natural role in the plant is defense.
Defense? What are they defending against?
They are part of the plant's chemical arsenal against environmental stressors like fungal pathogens and insect pests.
So the plant developed this defense protein to protect itself, and now it's making humans suffer from allergic rhinitis and PFAS.
Yeah.
When we talk about BET-V1 and the homologous food proteins, what exactly is the clinical takeaway for the listener?
Well, the central feature is their high degree of heat and acid lability. If you imagine a protein as a complexly folded origami structure, heat causes the PR10 protein to unfold and change its three-dimensional shape very quickly.
And that change is key.
It is. When the structure changes, the IgE antibody, which is shaped to recognize the original folded structure, can no longer bind to it. The structural change is what we mean by denaturation. This lability is why a patient sensitive to the raw apple protein, which is MAL-D1, the apple's BET-V1 analog, can consume baked apples or apple pie with complete safety.
And this BET-V1 cross-reactivity creates a massive web across the plant kingdom.
It does. It's a vast interconnected network extending to many staples, particularly those botanically related to the birch family. Common examples include apples, so MAL-D1, stone fruits like cherries and plums, hazelnuts, which is CORE1, carrots, DOS-C1, celery, ABG1, soy, GLE-M4, and even peanuts, RH8.
That's a huge list.
It is. And because birch is so prevalent, this PR10 pattern dominates allergy practice in Northern and Central Europe, Scandinavia, and North America. As we noted, in areas with high birch exposure, over 75% of birch allergic patients are affected by PR10-mediated PFAS.
Okay, moving on, we have the profilins. And these are often called the true pan-allergens because they are structurally so conserved across species.
Precisely. Profilins are even smaller, typically 12 to 15 kiloday. They are fundamental structural housekeeping proteins found across nearly all eukaryotic cells, which is why they earn the name panallergen.
Housekeeping proteins, what do they do?
Their job in the plant cell is to regulate the assembly and organization of actin filaments, which is crucial for cell movement, structure, and growth. And because this function is so fundamental, evolution has ensured their structure remains highly, highly conserved.
So if that structure is conserved, it means sensitization to one profilin, say, in grass. Pollen sets up cross-reactivity to an enormous number of other plants.
Absolutely. Sensitization to profilins from pollens like grass, that's PAAPP12, or ragweed, AMB8, often leads to reactions across a tremendously wide range of botanically diverse foods. Clinically, they cause mild, localized oral symptoms, mirroring the PR10s, because they are also highly heat and digestion labile. They break down easily.
What are some of the food examples that fall under the profilin umbrella?
The list is sprawling, reflecting their ubiquitous nature. Think peaches, Poo-P4, apples, MALD4, which is a secondary allergen, celery, APG4, melons, bananas, and tomatoes. Patient sensitized to profilins are often those individuals who present in the clinic with a long list of seemingly unrelated food reactions.
The ones who say, I react to a little bit of everything raw.
Exactly that. That immediately suggests a panallergen involvement.
Okay, so we have two major groups of labile protective panallergens, PR10s and profilins. Now we transition to the molecular dark horse. If lability protects us, where does this system fail? That leads us directly to the third critical family, LTPs, or lipid transfer proteins. This is where the risk profile changes dramatically and rapidly.
This is the critical distinction for diagnosing severity and ensuring patient safety. The prototype for this family is PRU-P3 from peach. Unlike the other two families, the key insight here is the LTPs is remarkable resilience. They are highly resistant to both heat and acid degradation.
So they're built to last.
They are. They are small, cysteine-rich proteins, again involved in plant defense, but their structure makes them built to last.
They survive cooking, and crucially, they survive the stomach. How does the structure facilitate that stability?
Well, LTPs achieve this stability through several strong internal scaffolding elements, specifically multiple disulfide bridges. These are strong chemical bonds between cysteine amino acids within the protein structure.
Like molecular rivets.
That's a great analogy. They act like molecular rivets, locking the protein into its shape. This internal stability means they don't denature when exposed to heat, so cooking, or when exposed to the high acidity and pepsin enzymes of the gastric environment.
By surviving that initial digestive phase, they bypass that crucial protective layer.
Correct. Their stability allows them to reach the gastrointestinal tract, the small intestine intact, where they can be absorbed and trigger a widespread systemic immune response. This feature makes them associated with a significantly higher risk of severe systemic reactions, including generalized urticaria hives over the body, severe gastrointestinal symptoms, or full-blown anaphylaxis.
And this mechanism explains why LTP allergy dominates certain regions, pushing the average severity rates higher than those regions dominated by birch pollen.
Precisely. The LTP syndrome is the dominant cause of food allergies and PFAS-like reactions throughout the Mediterranean basin in Spain, Italy, and Greece. This geographical pattern is a direct result of two factors: the high regional consumption of LTP-rich fruits like peaches and apricots, and the high environmental exposure to pollens, such as olive tree or plane tree pollens, which also contain LTP allergens that act as primary sensitizers.
So PRU-P3 from peach is the one to watch in that region.
It's the archetypal example and often the key diagnostic marker.
We mentioned nuts earlier. For a listener dealing with nut allergies, how does this molecular distinction help differentiate a true allergy from an LTP cross-reactivity?
It's absolutely vital. Besides peach, PRU-P3, the stable LTP family includes important nut allergens like hazelnut, Cory-8, walnut, Jugar-3, and peanut, Era H9. If a patient reacts severely to a nut in both raw and cooked forms, and component-resolved diagnostics shows IgE sensitization to one of these stable LTPs, strict avoidance is required.
This is a life-saving distinction.
It is. It differentiates a relatively mild PR10-mediated hazelnut cross-reactivity, which might be solved by roasting the nuts, from a much more dangerous LTP-mediated hazelnut allergy that requires an epinephrine autoinjector.
To round out the molecular picture, we should briefly touch upon the emerging and minor panallergens. We mentioned how complex this plant defense network is, and these proteins further illustrate that stability gradient we've been discussing.
We should. This reinforces the principle that stability equals risk. So we have the gibberellin-regulated proteins, GRPs, such as PRU-P7 in peach. Like LTPs, GRPs are small, but they are incredibly stable, partly due to that high number of internal disulfide bridges.
Meaning they also carry a risk of severe reactions. I recall the sources mentioning a specific syndrome tied to GRPs.
Yes, GRP sensitization, often originating from cypress pollen exposure, cup S7 in the Mediterranean, is linked to the cypress peach syndrome, which is another example of a geographically and molecularly defined severe cross-reactivity.
And there are others.
Then you have thaumatin-like proteins, TLPs, such as MUSA4 in banana or ACD2 in kiwi. They're also structurally robust and resistant to heat and digestion, meaning they are risk factors for systemic reactions. And finally, you have the less common players like isoflavonoid reductases and beta-1 under 3 hours gluconeses.
So while those names are complex, the takeaway for you, the listener, remains simple. It's not just what the protein is, but how sturdy it is. Labile means mild. Stable means severe.
Precisely. The molecular structure dictates the clinical outcome. If the protein structure is labile, like a PR10, the immune reaction is extinguished by digestion. If the protein is stable, like an LTP or GRP, it survives long enough to reach the bloodstream, raising the risk of anaphylaxis.
Right.
So moving from the microscopic world of molecular structure to the patient experience, the typical clinical picture of PFAS, especially when driven by those labile PR10s and profilins, is generally reassuring.
Right.
As we said, symptoms are almost always immediate, localized strictly to the oropharynx, the itching, the tingling, and they are self-limited, often resolving spontaneously within, say, 15 to 30 minutes.
That is the norm. But as we've established, systemic reaction symptoms extending beyond the mouth, like widespread hives, difficulty breathing, wheezing, GI distress, or low blood pressure, do occur. Globally, they are rare, reported in that 2% to 10% range.
Yep.
This is where we need to identify the specific cofactors that turn a mild, self-resolving oral annoyance into an emergency. So, if the protein is so labile, how does it ever get past the stomach? What are the cofactors that actually undermine that protection? Here's where it gets really interesting.
That's the fundamental question for risk assessment.
Yeah.
And we've identified several specific cofactors that essentially dismantle the body's natural defense against these labile proteins.
Let's start with the medication link, because the involvement of common over-the-counter and prescription drugs is genuinely surprising to most people.
It is a critical finding. We see a significant increase in risk with medications that alter the digestive environment. The use of proton pump inhibitors, PPIs, those are the common heartburn medications like omeprazole or lansoprazole that powerfully suppress stomach acid, is strongly correlated with increased prevalence of systemic reactions to otherwise labile plant food allergens.
Wow.
And similarly, the frequent use of nonsteroidal anti-inflammatory drugs, NSAIDs, such as ibuprofen, was also found to be more prevalent in patients who experience systemic symptoms.
That makes profound biological sense. Stomach acid and the enzyme pepsin are the first line of defense, designed to rapidly unfold and break down labile proteins. If you mentally disarming your digestive system.
Exactly. You are giving the labile PR10 and profilin proteins a temporary free pass. They remain structurally intact long enough to pass through the stomach and into the upper small intestine, where they can be absorbed and trigger a systemic reaction before they fully degrade.
And NSAIDs, what's the mechanism there?
NSAIDs likely increase risk through a different mechanism by causing minor damage or increasing permeability in the gut lining, which allows larger intact allergens to slip through the mucosal barrier into the bloodstream.
Beyond medications, changes to the gut architecture itself also pose a huge risk, specifically in surgical patients.
Yes. A profound risk factor identified through case studies is prior gastric surgery, particularly bariatric procedures like gastric bypass. We have reports of patients who had tolerated foods their entire lives or who had only mild oral symptoms suddenly experiencing severe systemic reactions, including full-blown anaphylaxis to common PFAS triggers like rosaceae fruits, tree nuts, and peanuts after their surgery.
That sounds absolutely terrifying. Why the sudden shift in reaction severity?
Well, the drastic alteration in gastric anatomy and function is the culprit. Gastric bypass reduces the volume of the acid-producing stomach significantly, severely restricting the time and capacity for acid and pepsin to work on labile proteins.
So the food just shoots right through.
The food bypasses the main digestive vat, traveling quickly to the small intestine, delivering a potentially massive load of intact labile allergen directly to the absorptive surfaces.
We also need to factor in underlying health conditions and medications that interfere with anaphylaxis treatment itself.
Absolutely. Uncontrolled asthma is a major cofactor for food-induced anaphylaxis generally. Inflammation already restricts the airways, making any allergic airway response more dangerous.
Sure.
Furthermore, the use of certain medications, specifically beta blockers or ACE inhibitors, can complicate the emergency management of anaphylaxis, potentially masking early symptoms or making the reaction resistant to the effects of epinephrine, which is a life-saving finding clinicians must be aware of.
And finally, a factor completely within the patient's control, the volume and speed of consumption.
This is often overlooked in clinic, but is hugely relevant. Excessive ingestion, particularly in concentrated liquid forms, we're talking fresh fruit and vegetable smoothies, raw fresh juices or soy beverages, or very rapid consumption, overwhelms the remaining gastric digestion capacity.
It's just too much, too fast.
Instead of receiving a slow trickle of a low allergen dose, you are delivering a significantly higher, faster allergen load of labile proteins than slowly chewing a single piece of fruit. The same caution applies to concentrated nut products or consuming massive handfuls of raw nuts very quickly. The sheer load just overcomes the system.
And timing matters, too. The season itself dictates risk.
Correct. Studies show that severe reactions are demonstrably more likely to occur during the corresponding peak pollen season. When the patient's immune system is already highly activated due to high circulating pollen counts, with IgE levels perhaps peaking and mast cells primed, this heightened immunological state lowers the reaction threshold, making it easier for a labile food protein to trigger a systemic response.
Okay, so we have a clear picture of PFAS in the Euro-American context, dominated by birch and those labile PR10s. Now, let's connect these concepts to the global context, using specific data to see how different environments produce wildly different cross-reactivity patterns and, crucially, different risk profiles. The data from the Korean nationwide survey provides a fascinating regional contrast.
This Korean study on patients with pollenosis is vital because it reveals unique dietary and environmental triggers that challenge the typical Western view of PFAS being universally mild. They found the overall PFAS prevalence in Korean pollenosis patients was high at 41.7%, similar to global rates.
Okay.
However, the severity data is what jumps out. The anaphylaxis prevalence reported in these PFAS patients was a striking 8.9%.
Anaphylaxis in nearly 1 out of 10 PFAS patients. That is a massive figure compared to the typical 1%, 2% generally reported in European or North American cohorts. Is this purely an LTP issue, or are there other factors at play in East Asia?
It forces us to ask deep questions about molecular and cultural variability. The study authors acknowledge the discrepancy, suggesting it could be due to more robust reporting, potentially broader inclusion criteria for anaphylaxis, or, most likely, a true reflection of increased severity driven by local allergens and consumption habits.
And the most revealing data comes from identifying the specific foods causing these severe reactions. Let's look at that list because it contrasts sharply with the birch apple archetype.
Absolutely. The most common anaphylaxis-triggering foods in Korean PFAS patients were peanut at 33.3%, apple at 22.2%, walnut at 22.2%, pine nut at 18.5%, peach at 14.8%, and uniquely, ginseng at 14.8%.
So peanut, walnut, and pine nut at the top.
Right. The high prominence of those nuts, all rich in seed storage proteins or stable LTPs, suggests that in this population, stable allergens are more likely involved in severe reactions, either alone or in co-sensitization with labeled allergens.
And the ginseng connection is a stunning cultural marker. I mean, it's a frequently consumed herbal preparation in many parts of East Asia.
It's a perfect example of how local diet defines the allergy. The study found that all ginseng anaphylaxis cases were explicitly sensitized to birch pollen. This suggests a specific birch cross-reactivity with the 17 keto allergens found in ginseng, which likely belong to the PR10 family.
So even though it's a labile PR10 allergen, the way it's consumed makes it dangerous.
Exactly. Its consumption in concentrated, liquid, or powdered form, often used medicinally combined with high birch sensitization, creates a highly dangerous scenario that we wouldn't encounter in, say, Sweden.
Beyond the food triggers, the study also identified patient characteristics that predicted anaphylaxis risk in Korea through multivariable analysis. What were the high-risk profiles?
The analysis revealed 4 independent key predictors for anaphylaxis. First, the presence of atopic dermatitis, or AD, was a significant risk factor. Patients with AD tend to have impaired skin barriers and higher systemic inflammation, which lowers the threshold for any allergic reaction.
Makes sense. What else?
Second, sensitization to specific pollens was key. Sensitization to hazel, timothy, or ragweed pollen were all independently associated with increased risk.
Wait a minute. Hazel and timothy are major sources of profilins or PR10's labile proteins. That suggests the severity isn't just about the stable LTPs, but also the strength or breadth of sensitization to the labile ones?
That is the crucial interpretation. It suggests that while LTPs are the molecular drivers of stability, a sufficiently strong sensitization, so high IgE levels, to certain labile allergens, combined with those cofactors we discussed, can absolutely push the reaction into the systemic category.
It's like a threshold effect.
Exactly. A threshold effect where sheer IgE quantity or breadth of sensitization overcomes the protein's lability. Finally, the fourth risk factor was simply the greater number of culprit foods. A patient reacting to many different foods has a more complex polysensitized immune system, which translates directly to higher systemic risk.
So the overall takeaway from this geographical comparison is that PFAS is not a single benign entity. It's a dynamic, globally variable syndrome where specific cofactors, dietary habits, and local panallergens dictate whether the reaction stays mild or becomes life-threatening. This emphasizes the need for highly accurate diagnosis. That complexity means that for you, the learner, accurate diagnosis is absolutely vital for two reasons: preventing unnecessary, anxiety-inducing dietary avoidance while simultaneously ensuring safety for high-risk individuals. The good news is that the diagnosis often starts and sometimes ends with a thorough conversation.
Diagnosis fundamentally starts with a detailed clinical history. And for classic PFAS driven by labile proteins, the history is often sufficient. The international guidelines agree that a diagnosis can often be made based on clinical history alone if 6 characteristic criteria are met.
Okay, let's nail down those 6 cornerstones of the clinical history that guide the diagnosis.
1. Symptoms must be provoked by raw fruits, raw nuts, or raw carrot celery. 2. Those same trigger foods must be tolerated when they're well cooked, canned, or roasted.
If we are dealing with labile allergens.
Right. 3. Symptoms must occur immediately, within minutes of ingestion. 4. Symptoms are exclusively localized to the oropharynx itching, tingling, mild swelling. 5. The patient has a history of seasonal allergic rhinitis or is known to be sensitized to pollen. And 6. The symptoms are generally mild and self-limited.
If a patient checks all these boxes, the diagnosis of PFAS mediated by those fragile labile proteins is highly likely.
Exactly.
But if the symptoms are atypical, if they are severe, if they involve vomiting or wheezing, or if they occur after eating cooked foods, we must move to objective testing. Traditionally, this means skin prick testing combined with the crucial prick-to-prick method.
Right, and standard commercial SPT for fruits and vegetables has severe limitations in diagnosing labile PFAS because the extracts are often prepared in ways that denature the heat labile PR10 and profilen allergens. This frequently leads to frustrating false negative results, even when the patient clearly reacts to the raw food at home.
Which is why the prick-to-prick testing, or PPT technique, is so critical in the clinic.
PPT bypasses the issue of commercial extract degradation. The method involves using the raw, fresh, unpeeled food item directly for the skin test. The clinician simply pricks the skin through a small piece of the raw fruit or vegetable.
And what's the key diagnostic pattern you're looking for?
The pattern that strongly suggests PFS driven by labile proteins is a positive PPT result to the raw food, but a negative test to the cooked, canned, or roasted form combined with that history of SAR. This pattern confirms that the allergenic protein is heat labile.
And specifically for nuts, where the stakes are so high, how does PPT help us differentiate between the different types of nut allergy?
It provides invaluable information. For tree nuts and peanuts, a positive SPT to the commercial extract, or raw nut, but a negative PPT to the roasted or cooked version, is highly suggestive of PFAS driven by labile PR10 proteins.
That offers a lot of reassurance.
It does. It suggests the patient is likely safe to consume cooked forms. Conversely, if the patient reacts strongly to both raw and cooked versions, that immediately signals the involvement of stable storage proteins, or LTPs, necessitating strict avoidance and a possible EAI prescription.
Moving to the cutting edge of allergy diagnostics, let's discuss why component-resolved diagnostics, CRD, has fundamentally changed how we approach PFAS. You called it revolutionary, and we need to unpack why.
CRD is revolutionary because it eliminates the guesswork inherent in whole extract testing. Instead of measuring IgE response to a complex mix of whole extracts, CRD measures IgE specifically to individual allergenic proteins or molecules. This molecular precision allows us to achieve two things simultaneously. First, vastly improve accuracy, and second, distinguish definitively between true primary allergy and clinically significant cross-reactivity.
And that distinction is the bedrock of personalized management. The platforms themselves are incredible. Can you take us through the most widely used molecular platforms, ImmunoCAP, ISAC, and ELIX, and contrast their utility in the specific context of PFAS management?
Certainly. First, ImmunoCAPI. This is a singleplex, quantitative assay. It provides precise numerical measurements in KUL for IgE levels to a single allergen component per test.
That's the workhorse.
It is. While narrow, it is excellent for targeted testing. If we strongly suspect birch-apple cross-reactivity, we target BET-V1 and MALD-1 levels.
Yeah.
It's also superb for monitoring, for instance, tracking PRU-P3 levels over time to see if an allergy is resolving or escalating.
So high precision in quantification, but narrow scope. What about the microarray chips that give us the broad picture?
That leads us to ISA, the immunosolid phase allergen chip. This is a powerful multiplex platform that tests for IgE to over 100 allergenic components simultaneously using a tiny microarray chip. It only requires a minimal amount of serum.
And for PFAS, that's huge.
For PFAS, ISAC is invaluable for initial broad screening, particularly in patients who report reacting to many seemingly unrelated foods. It helps us immediately identify sensitizations to the major allergens, PR10, profilin, and LTP all at once. This breadth helps untangle complex polysensitized profiles quickly. Its results, however, are semi-quantitative.
Meaning they give you a relative idea of IgE quantity, not a precise number.
Correct.
And then we have the latest evolution, ALX, or Allergy Explorer, which builds on that multiplex capability but adds a crucial layer of specificity.
ALX is highly advanced, testing for over 300 components simultaneously. Its key clinical advantage, particularly relevant in complex allergic patients, is the inclusion of cross-reactivity inhibition technology within the assay.
And what does that do?
This feature is engineered to enhance specificity, helping to filter out false positive results that are commonly caused by non-specific binding elements like cross-reactive carbohydrate determinants, CCDs.
Explain the CCD problem for the listener, because that often trips up standard allergy testing.
Sure. CCDs are sugar molecules found on many plant and indolent proteins. The body can produce IgE antibodies against these sugars. Crucially, these anti-CCD antibodies often bind to the sugar structures on hundreds of different proteins, leading to positive results on conventional tests for things the patient has never reacted to clinically.
Creating a terrifying, anxiety-inducing list of allergies that aren't real.
Exactly. ALX's inhibition technology blocks these anti-CCD antibodies from binding, providing a clearer, more clinically relevant picture of true protein sensitization.
So what's the immediate, actionable so what of CRD for the patient's safety and quality of life?
The CRD results provide molecularly precise management advice. If the patient is sensitized primarily to stable proteins, ProP3 or ARA-H9-LTP, for example, that dictates strict full avoidance of the food in all forms, raw and cooked, due to the high risk of systemic reaction.
But if it's the labile ones?
Conversely, if the profile is clearly limited to labile allergens, such as BET-V1 or a profilin, the patient can be confidently advised that cooked, processed, or tinned forms of the food are safe to consume. This dramatically reduces unnecessary dietary restrictions and significantly lowers patient anxiety.
Finally, the true diagnostic gold standard, the Oral Food Challenge, OFC. Given the clarity provided by CRD and clinical history, when is an OFC actually necessary for PFAS?
The OFC remains the gold standard for confirming clinical allergy, but we rarely perform it for straightforward, classic PFAS cases, as the history and testing are usually clear enough. It is reserved for complex or ambiguous scenarios. This includes complex net reactions where we need to definitively differentiate a potentially life-threatening primary stable allergy from labile cross-reactivity.
Or when the tests are just confusing.
Right, when tests and history are highly inconclusive. Or, as often happens in allergy clinics, to alleviate anxiety and improve diet diversity. We frequently use OFC when a patient, perhaps based on old generalized testing, is avoiding multiple foods unnecessarily out of fear. Confirming tolerance through a challenge under controlled conditions can alleviate significant anxiety and improve the patient's nutritional intake and overall quality of life.
And how does that work?
The challenge typically involves controlled, incremental doses of the raw food performed under strict medical supervision. Because mild oral symptoms are expected and common in PFAS, the challenge often needs to continue past those initial subjective symptoms to truly differentiate a self-limited PFAS reaction from a potentially escalating primary allergy. Now that we've established the molecular drivers and the precise diagnostic tools available, we turn to the international consensus on PFAS management. The core philosophy is clear. Personalized management built on education, selective avoidance, and aggressive risk mitigation, not blanket dietary restriction.
Education is key here because the mechanism is so often misunderstood.
It is paramount. Patients benefit immensely from deeply understanding the mechanistic basis of PFAS, the molecular cross-reactivity, and the heat labile nature of the proteins involved. This knowledge is therapeutic in itself, reinforcing the usually benign and self-limited nature of most reactions, which dramatically helps manage anxiety.
But you have to balance that.
You do. This education must be carefully balanced with robust awareness of the rare chance of a severe systemic reaction and how to recognize and treat it promptly.
This understanding dictates the dietary advice. What does the consensus advise regarding avoidance?
The consensus strongly favors selective avoidance. Patients should be advised to avoid only the specific raw food items that reliably trigger their symptoms, rather than being given a broad, anxiety-inducing list of every possible cross-reactive food based purely on their pollen sensitization profile. This highly personalized approach is crucial for maintaining nutritional balance and minimizing anxiety.
And the cardinal rule of managing labile PFAS cooking is usually the solution.
Absolutely. Cooked, canned, dried, or highly processed fruits and vegetables are almost always tolerated because the labile allergens denature upon heat exposure. This allows patients to maintain intake of vital nutrients, like vitamin C and fiber, even if they react violently to the raw forms. We must guide them toward safely prepared options.
But we need to caution listeners about what doesn't work, particularly concerning inadequate processing or high-risk consumption methods.
Indeed. It's important to understand the limits of this solution. We must caution that merely peeling the skin, where allergens are often concentrated, particularly for LTPs, or using light cooking techniques, such as quick steaming or stir-frying, may be insufficient to completely denature the allergens and prevent symptoms.
So it has to be cooked through.
The heat must be sustained and thorough. Furthermore, we must advise strict avoidance of foods that concentrate the allergen load. Raw nuts, soy milk, fresh fruit and vegetable smoothies, and juices, especially for patients who have any history of systemic symptoms or possess multiple risk factors.
And the nut caution bears repeating, particularly regarding roasting, which we might assume is a form of cooking.
For nut-induced PFAS, roasting or cooking is often unreliable. While heat helps denature some PR10s, it can paradoxically increase the allergenicity of other nut proteins, or simply fail to denature the PR10 allergens completely. For example, studies using double-blind, placebo-controlled food challenges with roasted hazelnuts in birch pollen allergic patients showed that many still experienced clear PFAS symptoms.
So it's not a guarantee.
Not at all. Due to this uncertainty and the high risk of stable storage proteins or LTPs being present, any nut reaction requires meticulous assessment, preferably using CRD. If CRD is unavailable, any reaction to nuts should be treated as higher risk than a fruit reaction.
For treating acute symptoms, if a patient gets that mild self-limited oral itch, what's the practical consensus advice?
Since the majority of symptoms are transient and self-limited, often resolving within half an hour, they often resolve spontaneously without intervention. If the symptoms are particularly uncomfortable or anxiety-provoking, a non-sedating antihistamine can be used for relief.
And does the form matter? Liquid versus pill?
Clinicians often note that liquid or chewable forms of the antihistamine may theoretically act more rapidly directly in the oropharynx, potentially offering quicker comfort and alleviating the patient's immediate distress.
Moving to the most serious aspect of management, epinephrine autoinjector, or EAI, prescription, who absolutely needs one.
Patients with a clear, confirmed history of a systemic reaction, meaning any symptom extending beyond the oropharynx, like generalized urticaria, wheezing, GI symptoms, or cardiovascular involvement, must be strictly managed with an emergency treatment plan and an EAI prescription. This is non-negotiable.
They are at a higher risk for future severe reactions.
Absolutely.
Well, what about the majority of PFAS patients who have never had a systemic reaction but might have those concerning cofactors we discussed, like being on a PPI?
For individuals with non-systemic PFAS who possess identified known risk factors for severe reactions, the use of PPIs, NSAIs, beta blockers, a history of gastric bypass surgery, or uncontrolled asthma, a shared decision-making approach regarding EAI prescription is advised.
A conversation between the doctor and patient.
Yes. The discussion involves balancing the very rare risk of a severe reaction against the financial and psychological burden of carrying the device daily. This conversation must be ongoing, transparent, and tailored to the patient's lifestyle and compliance potential.
Finally, let's address immunotherapy. Since PFAS is rooted in pollen allergy, is treating the underlying pollen allergy with AIT effective at resolving the food reactions?
The current international consensus, supported by both the Delphi and BSACI guidelines, is firm and clear. PFAS is not an established indication for pollen allergen immunotherapy, AIT, regardless of whether it is delivered via subcutaneous injection or sublingual tablets.
That seems counterintuitive. AIT is highly effective for reducing allergic rhinitis symptoms. Why does it fail to consistently help with the food cross-reactivity?
Well, the reason lies in the molecular complexity. While AIT successfully trains the immune system to tolerate the primary pollen allergen, say BET-V1, this tolerance doesn't always translate perfectly to the cross-reactive food protein, like MALD-1.
The immune system is too specific.
It seems so. One key study found that SLIT with birch pollen extract successfully improved the patient's rhinoconjunctivitis, but it failed to significantly decrease their symptoms of apple-induced PFAS, nor did it alter the immune response to the MALD-1 protein. The immune response built up against the pollen is often too specific to recognize the subtly different three-dimensional structure of the food protein analog once it hits the mouth.
So you have to tell patients not to expect it to fix their food issues.
Clinicians must counsel patients that the primary goal of AIT is respiratory symptom relief, and we cannot reliably guarantee it will resolve their food cross-reactivity.
What about using oral immunotherapy, OIT, to directly address the food, like eating incremental raw apple portions?
OIT, which is essentially exposure therapy using the food itself, has shown promise in specialized research settings. One notable study randomized birch-sensitive patients to either daily incremental consumption of raw apple or complete avoidance. After 8 months, the apple-consuming group demonstrated significantly increased clinical tolerance, suggesting that oral tolerance induction is possible for labile food proteins.
But it's not standard practice.
No, the protocol is highly time-consuming, requires close monitoring, and is currently not standard clinical practice. The consensus is that OIT for PFAS might only be offered in a research or highly specialized clinical capacity at this time.
We've taken a major deep dive today. PFAS is a truly fascinating study in molecular confusion and cross-reactivity, driven primarily by the fragile labile panallergens like PR10 proteins and profilins, which usually keep symptoms contained and mild.
But the narrative shifts entirely when those stable molecular structures, LTPs, GRPs, enter the picture, or when certain critical cofactors intervene. And that is the crucial learning nugget we uncovered today. We've seen that common, often innocuous daily factors, such as taking PPIs or NSAIDs or consuming excessive allergen loads via smoothies or concentrated herbal products, can dismantle the body's natural protective mechanisms. Gastric digestion, turning a usually mild oral itch into a severe systemic reaction. Vigilance is paramount in those high-risk scenarios.
The rapid evolution of diagnostics is also changing the game. We've moved beyond generalized skin pricks to component-resolved diagnostics, ImmunoCAP for precision, ISAC for breadth, and ALX for specificity, which give us the unprecedented ability to look directly at the molecular culprit.
That molecular specificity is the future of management. Understanding your specific allergen profile via CRD allows clinicians to move away from unnecessary broad dietary restrictions, which only increase anxiety and limit nutrition, toward a highly personalized, selective avoidance approach focused on safely prepared foods and actively mitigating those surprising risk factors in your medical history and lifestyle.
So what does this all mean for you, the learner, looking ahead?
It means we must think proactively about tolerance induction. The sources noted that allergen exposure protocols, specifically oral tolerance induction or OTI, achieved through early regular dietary exposure, are currently being evaluated for preventing secondary food allergies in children. This research builds on the understanding that the immune system needs regular, controlled input to either build or maintain tolerance.
That raises a final provocative thought for you to consider as you wrap up this deep dive. If we know that regular exposure to an allergen is necessary to build tolerance, and if the labile PR10 proteins are denatured and rendered harmless by cooking, could we potentially prevent PFAS from developing in highly pollen-sensitized children by introducing cooked, low-allergen versions of cross-reactive foods like baked apples or well-cooked carrots early and regularly in their diet, ensuring the immune system sees the protein but only in a safe, non-reactive form?
That is a profound question currently driving major research into primary and secondary food allergy prevention.